Good evening, everyone, and welcome to the third and final lecture in our DocTalks series. I'm Karen Perkin. I'm the Vice President, Patient Care and Chief Nurse Executive at St. Joseph's Healthcare London. We host tonight's presentation in partnership with our foundation. Many of you joining tonight are supporters of the foundation, and for that, we are very grateful. It is through your generosity that St. Joseph's is able to invest in specialized care for you and your families. I want to acknowledge CIBC for sponsoring our DocTalks lecture series. CIBC is committed to fostering healthy communities across Canada, and we are very thankful for enabling us to be able to put on these community health discussions for you. These virtual lectures are an opportunity for you to hear good health information directly from the experts themselves. There are so many bright minds here at St. Joseph's in London and Lawson Health Research Institute, which is the hospital's research arm, who are all working on new treatments to illness, injury, and disease. Someday you or someone you know will benefit from the medical innovations that our scientists are working on today. Tonight's topic concerns a subject nobody wants to experience during their lifetime. Passing a kidney stone can be acutely painful. Some people even compare it to the pain of childbirth. If you've ever had a kidney stone, you know what I'm talking about. Fortunately, tonight's presenter is well versed on the subject of kidney stones. Dr. Hassan Razvi is a professor in the Division of Urology at the Schulich School of Medicine and Dentistry and at Western University. He is also the former chair chief of urology at St. Joseph's, having been in that role for 14 years. During his career, Dr. Razvi has held a number of leadership positions and is currently a representative in the American Urology Association's Board of Directors. He also serves on the board of Endourology Society and is a member of the editorial boards of the Journal of Endourology and the Canadian Urological Association Journal. His clinical and research interests include the metabolic and surgical aspects of urinary stone disease and surgical device development. He has authored 18 book chapters, and he has published more than 190 peer-reviewed journal articles. And tonight, he's going to share with us the secret of the stones. Ladies and gentlemen, Dr. Hassan Razvi.
Well, thank you, Karen, for that very kind introduction. And I'd just like to also echo my thanks to our sponsorship, CIBC, for sponsoring this evening's event. I'd also like to thank the foundation for, first of all, the invitation to speak at this event and for all the logistics and organizing it. So tonight's topic, secrets of the stones. So maybe before I dive into this, just so that we're all clear and everyone's at the right lecture, I know there'd be lots of interest in hearing about the secrets of the Stonehenge stones, those giant monoliths in Salisbury Plain, and lots of mysterious and questions, I suppose, around their existence. But I will restrict my commentary this evening to the human kidney stone, which is, I would say, for people who have suffered through a painful kidney stone episode, also something that invokes many questions and clearly is something that a patient was not wanting to go through again. So in the next 30 minutes or so, what I'm going to try and address are some of the common questions that our patients ask us, hopefully to dispel some myths that perhaps you've heard, and to give you a sense of how we manage kidney stones currently, and maybe just a little bit of a glimpse into the future. So I thank you all for attending this evening. So the objectives I'd like to cover then through the rest of this presentation is, first of all, the what. What are kidney stones? What are some of the statistics that are quite interesting? Why? Why do these things actually form, and why are they important for health? And then finally, the how. How do we treat them, and how, most importantly, I believe, can we prevent them? So what exactly are kidney stones? So these are abnormal collections of minerals that develop within our kidneys, and these are not unique, of course, to humans. Other mammals develop them as well, and it's an intrinsic problem that develops as a result of the functioning of the kidney, and we'll talk a little bit about how this happens in a moment. There are 5 major kidney stone types that are listed here on this slide. The most common one by far is the calcium oxalate or calcium phosphate stone, which accounts for at least 70% of kidney stones. And on this slide here, we see some of the crystals that are really what starts a kidney stone developing. And of course, they look quite beautiful on these slides, of course, unless you've had a stone, and then perhaps they don't look quite as appealing. So just a little bit about basic anatomy. The urinary tract, the little box on the right there shows how the urinary tract is constructed. We, of course, have our 2 paired kidneys with the 2 ureters. The ureters are what convey the urine to the bladder. Bladder is situated, of course, in the pelvic cavity. And then, of course, we have the urethra, which transmits the urine externally. And looking at the kidney in a bit more detail on this right-sided panel, the kidney really is made up of 2 components, if you will, what we call the parenchyma, which is this red or pinkish part, which is the filtration part of the kidney. Think of a sponge. That's essentially how the kidney works, in fact, as a filter. And it, of course, filters all the wastes from the bloodstream and then produces the urine and liberates the toxins from the body via the urine. Kidney stones develop in what we call the collecting system, or the second part of the kidney, which is shown here in pink. And you can actually see these round stones here, and these would be stones that would be forming over time. Depending on where they're in the kidney, they may grow to quite a size. And really when they begin to cause symptoms is typically when they move out of the kidney and into the ureter. And this pink circle here is showing a stone that has lodged itself in the ureter. And of course, when that happens, that's usually when patients are becoming aware they have a stone, because the urine flow is impeded, the kidney is blocked, it can't excrete the urine, and that's usually what causes the excruciating pain that people have heard about. So some statistics, stone disease is a very important health concern, and the reason for that is it's quite a common condition. The current statistics are about 11% of men and 7% of women will be afflicted at some time during their life. What's rather interesting is when I was a medical student, we were told that the incidence was about twice as common in men than in women. But what we've really seen in the past 15 to 20 years is a narrowing of the gender gap, and we're seeing many more women afflicted, particularly in the younger age groups under 30. It's not exactly clear why we're seeing this, but it is something that's been observed across the globe. We're also seeing an increase in stone disease among children, and this also raises a number of questions as to why that's happening. Many theories, but at the moment, we're not exactly certain why that is happening. The other main problem with kidney stones is if you've had one of them, there's a very high chance of another, 50% perhaps or more in 10 to 15 years. That is assuming you don't correct the reason the stone formed in the first place. The peak ages are typically 30 to 50 years of age, but really all age groups can be afflicted. And what we also observe is if there's a family history, that does increase the risk significantly, maybe up to 3 times. This publication that came out in 2017 was an attempt to try and determine why we were seeing the increase in stones forming across the world. And they looked at a number of factors and proposed some theories which are interesting. As you might expect, of course, as the world population grows, we're going to see more kidney stones. But they also identified substandard diets. And this is not just in the third world, but even in first world countries. We're seeing obesity and diabetes epidemics across the world. These 2 conditions are linked to kidney stones, so may also be attributing. And also, it's been noted climate change may be impacting kidney stone formation due to increased temperatures, which lead to dehydration, which is in fact one of the major causes of kidney stones across the world. The other important statistic about kidney stones is that this is a major healthcare issue from an economic perspective, and stone disease is costly. There aren't good Canadian figures, but if we look at some US data from 2015, the annual estimated cost for treating patients in the United States with kidney stones was $5.3 billion. And that just includes the direct costs, things like emergency room visits, investigations that are required. If a patient has to be admitted to hospital, the cost of the inpatient hospital room, if they require surgery or some type of procedure, the operating room expenses, and perhaps they need medications as well. So quite a significant economic impact. What that data does not include, however, are the indirect costs, which are probably even more, and that is for patients who have pain that takes them out of their work environment or impacts their quality of life in other ways, other costs that are really not accounted for. And the other thing that's really quite important about kidney stones, which is something that I think has only been recently appreciated, and this comes from actually some Canadian data, is that kidney stones may actually be a surrogate for other health conditions, and in particular cardiovascular disease later in life. And why that is exactly is not completely elucidated, but it's thought that perhaps kidney stones, perhaps due to dietary issues or perhaps some lifestyle changes that are negative, may in fact impact heart and brain function and diseases later in life. So kidney stones are not just kidney stones. There may be some other issues that that may be important later in life. Again, looking at some data in the US in terms of what we might be facing in the future, just in terms of the costs of kidney stones, suggests that we are likely to face some significant health economic pressures. This graph here shows how obesity, diabetes, and just the increase in population will potentially increase the cost of caring for patients with kidney stones. And out to 2030, if we add all of those conditions together, we're looking at least $10 billion US per year to manage patients with kidney stones. And so that's a fairly significant healthcare cost. Canadian population, about 1/10 of the US. You might then extrapolate that for Canada, that may be $1 billion perhaps or more to care for the Canadian patients with kidney stones. Not an insignificant number to consider. Well, why do kidney stones form? And I suspect this is probably one of the more common questions patients ask their physician when having had one of these, because of course they want to do whatever they can to avoid a future stone. And there are lots of reasons. There are numerous medical conditions which can predispose people to kidney stones. There are what we call anatomic factors, and these two slides, pictures here on this slide are showing some conditions which may be congenital, where the kidney malformed, which predisposes people to the development of a kidney stone. We also know that dietary problems are a significant cause for kidney stones, which include things like dehydration, obesity, excesses of certain nutrients such as sodium, protein, oxalate. We'll talk a little bit about some of these things a little bit later when we talk about prevention. We also know that in Canada in particular, vitamin D lack is also a significant risk factor as well. Some parts of the world, excess vitamin D can be an issue also. Finally, we know that genetics plays a significant part in kidney stones, and there are actually some conditions that are genetically based and a little bit more difficult, obviously, to manage because of that. Well, how do we detect kidney stones and how do we manage patients once they have one? Well, it's interesting, over time, and mostly because of technology, we are finding more patients with kidney stones incidentally. They're having investigations perhaps done for other causes, and ultrasounds and CT scans have now got to be very high quality in terms of their ability to detect pathology, including kidney stones, and so oftentimes this is how we first find that a patient has a stone. Most people have probably heard, though, about the typical presentation of what we call acute renal colic, which is another way that patients will present. This is that excruciating pain, which typically begins in the flank. Most patients who have been through this state that it's the worst experience that they've ever had in terms of pain, worse than breaking a bone, worse than having labor without anesthesia. It's often described as just the worst experience that they've ever had. Sometimes we'll hear patients present with blood in their urine, what we call hematuria. And then finally, we may see patients who present with things such as kidney failure, where the kidneys have been damaged as a result of significant kidney stone burdens, or some patients who have urinary infections, which have developed because of kidney stones, perhaps blocking or impairing the flow of urine. Of course, the other question that patients ask us once they know they've had a stone is, how do we treat them? And so the good news is that for the majority of patients who have a stone, we in fact don't need to do very much, and they may pass their stones without intervention. What is quite critical, though, in terms of the potential for a patient passing a kidney stone or not on their own is the size. And figures that we usually quote to our patients are the ones listed here on this slide. The smaller stones, 4 millimeters or less, a very high chance of stone passage. Once stones get above 8 millimeters, however, it becomes much less likely. Stone location also has something to do with the possibility of stone passage, depending on where in the ureter in particular the stone is located. Stones that are in the lower ureter, that is closer to the bladder, typically have a higher tendency to pass, simply because they have less distance to travel. So I've stated that for many patients, no active treatment may be required and they may pass their stones on their own. But there are some reasons why we may need to intervene urgently, and these are some of the indications. The most common one, of course, is that a patient is having intractable pain that we really are unable to control adequately with the current pain medications at our disposal. Patients who have a stone with a fever or a urinary tract infection can get quite ill. So-called sepsis is a risk in this scenario, so we may intervene earlier in that situation. Patients who have a stone and have underlying kidney disease or maybe a solitary kidney, these are patients that are at higher risk for kidney failure and therefore may require urgent intervention. And then finally, we do sometimes consider social factors, occupation as an example. People who are in occupations where, of course, if they had an acute attack of pain from a stone, where they're looking after other people, that may be a significant concern and risk. So things like pilots, military personnel, first responders, we will often intervene to deal with their stone rather than waiting for them to pass it spontaneously. Well, if the patient is unable to pass their stone, then what? What are our options? And so the good news is that there really has been quite an evolution in the treatment of kidney stones over the past 20 years. And the role for major invasive surgery now has become very uncommon. And fortunately, we have a number of relatively minimally invasive procedures, and I'd like to review some of those next. The first one, which I suspect many in the audience have probably heard about, is shockwave lithotripsy, or the so-called stone machine. And I'm showing two pictures here. The very first lithotripsy machine here on the left, the Dornier HM3 as it was called. This was first made available for clinical use in the mid-1980s. I think many people have heard of the so-called bathtub lithotripsy machine. Well, that's what this is. So the patient had to be submerged in this water bath. The water was the coupling medium. It's the way that the shock waves delivered from this energy source here shown on the right of the picture delivers the shock wave energy to the patient, but it has to be coupled to the body in some fashion, and that was what the water was for. Well, fast forward now to 2022, and the state-of-the-art shockwave lithotripsy machine is the one pictured here on the right, and the one that we have here at St. Joseph's Hospital in our operating room. This now is a machine that has completely removed the water bath. The patients lie on this table here that I'm pointing to, and that bathtub that's in the old lithotripsy device has been replaced with what we call a water cushion, which is a fluid-containing structure here, which allows that targeting of the water to the patient's body to allow the shock waves to be delivered. So quite a evolution there in the technology, certainly since the very first machine was used. And many people ask, how does shockwave lithotripsy work? It's kind of almost a science fiction type of concept, but really is a tremendous mechanical feat, if you will. And essentially what we do with this treatment is a generator which produces these shock waves, which are then targeted toward the stone using some type of imaging device. And typically most of the shockwave machines use what's called fluoroscopy, or a type of X-ray. And by coupling that shockwave generator to the patient's body with some type of fluid, we then can allow the shock waves to then hit the stone, with the concept of trying to break up the stone into small pieces that are now passable. So if the patient had a 1 centimeter stone, perhaps, for example, we're going to try and make that as small as we can so that now those pieces are 4 millimeters or less, so they will be able to pass spontaneously on their own. The other minimally invasive option we may consider is a procedure called ureteroscopy, and there are various endoscopes that are shown here on this slide with various shapes, configurations, depending on where in the urinary tract we need to insert them. And typically, these endoscopes are used with some type of imaging modality, such as X-ray, so we know where we're advancing them, and also use a device to break up the stones, such as a laser. And in this next slide here, you're going to see a small vignette of a laser using to break up a stone within the ureter. So this is a telescopic procedure. That blue that you're seeing is the laser fiber. The red is the aiming beam that we use, so we target the stone, we touch the laser to the stone, and then as we work, we're chipping away at the stone into very small pieces, and most of it's like sand-like particles, which are going to wash out through the urine very, very readily. This is typically a procedure we do under an anesthetic, but is an outpatient treatment, and patients typically go home later in the day after this procedure. Unfortunately, however, we do also have patients who sometimes have much more significant stone burdens, and these are two X-rays showing patients who essentially their kidneys are completely full of kidney stones, and for this scenario, we do require other types of treatment. The two that I've previously described, the shockwave lithotripsy and the telescopic ureteroscopy procedure, would not be appropriate in these settings. So typically what we do is another type of telescopic surgery called percutaneous stone removal. And this does require a small incision in the back, usually about 1 centimeter, and it's usually just large enough to put a very specialized telescope into the kidney, which we can then pass instruments to break up the stones and even then aspirate them or remove them. And some of these telescopes can use various baskets and other devices to try and extract the stones. So really a much less invasive option than what we may have had to have done 20 years ago, where we would have been making very large incisions in the patient's body, such as the one you see here on the right hand of this screen. Thank goodness we don't do this very much anymore because of the technology, and we've finally been able to heed the advice of Hippocrates, who really was cautioning physicians almost 2,500 years ago to not cut patients to remove kidney stones. So we've finally been able to accomplish that. At this point, I'd like to just acknowledge as well the St. Joseph's Hospital Foundation, who have been instrumental in making available some of the technology that I've just described to you here this evening. Really, without their support and with support of donors, it would have been impossible to have this equipment. And we are very blessed, the physicians that work here at St. Joe's in our urology department, to have state-of-the-art equipment. That shockwave lithotripsy machine I previously have shown you is supported by the foundation. Our various telescopes that we use for stone surgery also supported, and also a very interesting tool that we're using to train the next generation of surgeons is what we call a surgical simulator, which allows our residents and fellows to actually learn how to use these tools before they actually use them on patients. And that was also supported by our foundation. Well, that's how we treat stones, but I think, as I said in my initial remarks, I think one of the most important things about kidney stones is prevention, and I think Benjamin Franklin had it right when he said an ounce of prevention is worth a pound of cure. And so for kidney stones in particular, this is an area that I think we need to do better, and there's lots of research and activity going to try and make prevention a much more effective way of managing patients who are at risk of kidney stones. And so how do we currently prevent them? Well, this tip here is not completely inaccurate in that if you drink a lot of fluid, that can help prevent kidney stones. Probably don't need to drink a gallon, but certainly it does reduce some of the drama of having acute renal colic, that is for sure. We also know diet has a significant impact, and we know that certain parts of the world have lower risks of kidney stones, and the Mediterranean is one of them. And of course, it's thought that their diet, which is very much plant-based, may have some impact on this. And so we are learning more and more about the importance of diet, I think. There are a number of diets, as you probably are aware, and if you just Google any diet in terms of weight loss reduction, kidney stone prevention, you're going to find many, many things. A lot of them have not been really properly tested, but one of them that has been is what's called the DASH diet, and many of you may be familiar with this because it's a diet that was actually developed in the treatment and prevention of hypertension or high blood pressure. Well, there have been studies that have also shown that this diet as well can be very helpful in reducing the risk of stone formation in people who are at risk. The components of the DASH diet are fruit that is, or a diet that is high in fruit and vegetables, moderating the dairy, and it should be low fat, and minimizing animal protein intake. And as I said, this can also have an impact not only on stone formation, but in general health, and certainly reducing blood pressure can reduce risk of heart and stroke disease. So that really is the key when we talk to our patients about diet and stone disease, is that typically a diet that is good to prevent a kidney stone is also good for your heart, maybe good for your gastrointestinal tract, and also for your bone health. They really are very similar. The key element in preventing kidney stones, though, as I alluded to already, is avoiding dehydration, #1 risk factor. So our typical guidance to patients is to try and drink at least 2.5 liters of fluid per day. The goal is really to try and make 2.5 liters of urine per day, and so that will fluctuate a little bit based on a person's activity level, the ambient temperature, the time of year, because of course middle of summer you may need to drink more fluid than you have to in the middle of the winter. But a good goal is to try and achieve a 2.5 liter urine output per day. There have been a number of studies that have also suggested adding citrates such as lemon juice or lime juice to beverages also may have a protective effect. Lemons and limes are high in citrate, which is actually something that our kidneys normally produce and will help to prevent kidney stone formation. One of the most significant risk factors for kidney stones in Canada is excess salt or sodium intake. And it's really quite alarming when you actually look at some of the statistics in terms of how much salt we need versus how much we actually take in a day. And there have been some studies done that suggest that the Canadian diet is perhaps one of the highest in the world for salt intake, and the average Canadian takes in about 3,400 milligrams of sodium per day. It's thought that we only need about 2,300 or less. And so just to put that in perspective, how much sodium do you get from various foods? And so on the slide there, you can see a few examples. So, a tablespoon of soy sauce, gets you almost a half of your daily sodium required intake in a day. So this is a significant issue. And the reason this is so important is the extra salt that we take in our diet is liberated from the body through our urinary tract, through the kidneys. And when the extra salt is passing through the kidney, it also draws calcium into the urine, which is what often predisposes people to calcium stones. So reducing the dietary sodium intake can have actually a very significant impact on people who are prone to kidney stones that are of calcium origin. The other issue that is quite prevalent in the North American diet is the animal protein intake, and many of us intake much more protein than we actually need. That's also been linked to the development of several types of kidney stones. It's currently recommended that for most adults, our dietary protein intake should be about 6 to 8 ounces per day. That's about 150 to 220 grams per day. Most of us exceed that. And a good guidepost, if you will, as to how much am I really taking in when I'm having a meal is some advice that our dietitians give our patients, and that is you shouldn't have a protein intake that is larger than a deck of cards for each meal, and that's a really good way to think about it. Oxalate is another common cause of kidney stone problems, and there are a number of foods that are very high in oxalate, and oftentimes if patients intake more of these than perhaps is required or recommended, that can put them at risk. If you've done any research, though, on what are the foods that are high in oxalate, you'll notice that many of them are actually very healthy. And I've listed a few of them here, such as spinach, kale, nuts, rhubarb, strawberries. These are things that, honestly, we should have in our diet. It's just how much and what kind of portion sizes are we talking about, but certainly there may be some reason to restrict, but never eliminate those things from our diets. A little strategy as well that we found helpful for patients who maybe are at risk for recurrent stones that have calcium is to consume their oxalate-rich foods with some dairy at the same time. And this is some way, or is one way to perhaps reduce the amount of oxalate that their bodies absorb, and therefore they can get the healthy benefits of those foods without the risk of producing very high oxalate levels. On select indications, we'll also use medications to help prevent certain types of kidney stones, and we'll often do investigations in people who've had recurrent kidney stones to identify whether or not they might benefit from some of these treatments. And I've listed some of the medicines here that we will use. A number of them are used quite frequently, others a little less commonly, particularly the ones for the very rare genetic conditions. But the good news is we do have some medical preventions which can be effective in the right patients. One of the questions I frequently get asked is, how about vitamins and supplements? Is there any role for them? And the answer is, for some, yes, and perhaps for some, maybe not so much. Calcium intake is a very important part of a healthy diet, and there was advice that used to be taught to us, even as physicians 20 years ago, was that if you had a kidney stone that was calcium-based, then you should cut out all the calcium in your diet, do not take any supplements, avoid dairy. We've actually found that that advice is not helpful, and in fact may produce more kidney stones. So we do not tell people to restrict their calcium. What we do say is it should be moderated, and so typically for an adult that would be 1,000 to 1,200 milligrams a day. Best taken in a dairy form, but if you are unable to take dairy, perhaps due to GI intolerability, taking a calcium supplement is quite appropriate. Typically, we recommend taking it with meals. That allows better absorption and perhaps avoids excessively high levels being produced in the body at one time. Vitamin D, I think I mentioned earlier, is another issue that, particularly in Canada, we found is a problem, and particularly in the winter months because of our shorter days. Vitamin D of 800 to 1,000 international units a day will not produce kidney stones, and in fact may be beneficial in reducing the risk of stones, and also very protective for bone health. Vitamin C, we have noticed that very high intake of vitamin C actually can lead to kidney stones. So the current recommendation is 1,000 milligrams a day or less, and not more than that. Many patients ask about magnesium. There is some conflicting data on this one as to whether or not there's a benefit or not. The bottom line at the moment is the studies have not been adequately conducted to know for certain. I think there's more research that needs to be done in that area. Online, you'll see lots of other recommendations: apple cider vinegar, cranberry pills, the list goes on and on. The bottom line here is, again, most of these supplements have not been adequately studied in a placebo-controlled fashion, which really is the standard for assessing new treatments for effectiveness. And so it's not to say that these supplements may not have a benefit, it just hasn't been proven yet. And there is research ongoing, I think, on a lot of these various supplements. I know that in the US, there's a couple of studies going on about apple cider vinegar, which is one of the more common remedies that you'll find online. But I think we have to stay tuned to know whether or not there's any benefit to these things or not. So finally, to wrap up here in the next few minutes, talk a little bit about the future, because I think there's some very exciting developments on the horizon here in terms of advancing the care of patients who have kidney stones. And I think the one area that has garnered a lot of attention is the genetics. And this is an area that we really have, I think, a very limited knowledge about why certain people will get kidney stones. And as for many other medical conditions, gene modification is something that is being actively studied. If we can identify people before they get a certain medical condition, like a kidney stone, and perhaps we can alter their natural history so that that event, that kidney stone passing, never actually happens. And so there's work ongoing in this. I think there's also some exciting developments in terms of medical prophylaxis. Just in fact, within the past year, this drug called lumaricin has been developed, which is a drug to treat a genetic condition that produces kidney stones in children. And it's been shown actually to almost completely eliminate the development of kidney stones in those patients at risk. This is really a game-changing kind of intervention, and certainly very exciting, and hopefully one of many. A group of us here in London and working at the Research Institute at Lawson have been working on some other novel medical treatments as well, and one of them that has undergone some very early clinical trials is something called arbutin, which may have some benefit in preventing calcium oxalate stones. So we're really excited about moving forward with some more clinical trials looking at the effectiveness of this agent. I think where we've not had much headway made is how do we dissolve kidney stones once they form, and this is something that I think the future research hopefully will help to solve. And then finally, less invasive treatments, and I think this is where there's been some actually incredible technology developed, and we're seeing smaller telescopes being developed that are less invasive and less injurious to the patient's tissues. better tools such as lasers, which can break up stones quicker into smaller pieces, which make it easier for patients to pass their stones. And I think one area that is absolutely incredible to think about is something called ultrasonic propulsion and burst wave lithotripsy, which is almost something out of Star Trek, if you can believe it. So this is just some very basic diagrams here showing this concept, which is a project that actually was initiated by NASA. And the thinking here, of course, is that with prolonged spaceflight, in all likelihood, there's going to be an astronaut that gets a kidney stone, and how are you going to manage that if they're halfway to Mars? Kind of frightening to think about, how that could be taken care of. And so a group at the University of Washington working with NASA have been working on some very, very novel technologies where you might actually be able to move a kidney stone externally using special ultrasound waves, which can maybe move the stone if it's lodged in the patient's ureter into the bladder, making the pain go away almost immediately. And perhaps coupling it with something called burst wave lithotripsy, which is similar in concept to that shock wave lithotripsy I earlier described, but using a much different type of wave, which is in fact relatively painless to the patient. And they've actually started some studies treating patients in the emergency department or even in their clinic where they've got a stone that's causing symptoms, and not having to take the patient to the operating room or to give them an anesthetic. So really incredibly exciting types of treatments on the horizon. And so we're all, waiting patiently to get more results and hear how this is going to be available to our patients here on terra firma, not just out in space. So perhaps at this point I'll stop talking and open it up for some questions. I'd like to thank the Foundation once again for supporting this evening and for the invitation to speak. And I'd like to thank you all for your attention and look forward to taking some questions. Thank you very much.
Well, thank you, Dr. Razvi, and good evening, everyone. My name is Ryan Byrne. I'm a member of the Foundation team here at St. Joseph's. This is the time where we get to address some of your questions, and thanks. There's already been several questions that have been submitted here, so I'm going to go through this, and Dr. Razvi would love your input and advice here in some of these questions. So the first one, why is it so difficult to control the pain of kidney stones in some patients?
Yeah, it's a terrific question. And the real issue here, of course, is the type of pain that happens with kidney stones. And not to get too technical here, but it's what we call visceral pain. And it's a little different than the type of pain, say, when you cut yourself shaving or you cut yourself with a knife and you experience that type of pain, which is what we call somatic pain. It's a different type of nerve, essentially. And the problem with that kidney stone pain is it's a very deep-seated. It really, a lot of nerves are involved in sensing that pain and transmitting the pain to the brain. And so it's a much more intense type of pain. And so the typical pain medications that we might use for that somatic or cutting your skin type of pain sometimes are not as effective. And so it often requires higher dosages or maybe even more than one type of pain medicine to really adequately control the pain. So yes, that is a significant issue. And as I said in my presentation, it's one of the reasons why we will intervene early in a patient's course of disease if they have that intractable pain, which is not uncommon.
Thank you. And it was great to learn about lithotripsy in the presentation, and we had several questions come in. One of them, is the patient asleep during lithotripsy?
Yeah, so the way we perform lithotripsy here at St. Joe's in our suite is with what we call conscious sedation or IV sedation. So patients are not feeling any pain as we're doing the treatment, but they're breathing on their own. We can rouse them very easily if we needed to, but essentially they have a 35, 40-minute nap. And then the anesthetic is very short acting, so it wears off, and that allows them to go home fairly quickly after their treatment.
Great. And what determines if lithotripsy is an option for patients?
Yes. Well, a number of factors. So as part of our investigation of the patient who has a kidney stone, we'll be looking at the imaging testing that they have done to identify the size of the stone, where in the urinary tract it's located. And depending on the type of imaging they've had done, we may get some other information about the density. How hard is the stone? and how far is the stone from the patient's body surface. And so these are some things that sometimes will give us some clues as to whether lithotripsy is even worth considering. We do know that very large stones, perhaps stones that are very, very hard, and there are certain types of kidney stones that are like this, that maybe lithotripsy is not the best answer, and we would then resort to other options. So yes, we'll rely very much on our imaging to guide us as to which treatment to choose.
Great, thank you. A couple of questions as well about medullary sponge kidneys. I'm not sure if I'm saying that right, but if someone has medullary sponge kidneys, can they end up in kidney failure?
Right. So medullary sponge kidney disease, I think, is what you're referring to, and yeah, not an uncommon condition, and patients with that condition are more prone to kidney stones. It's true. Kidney failure requiring dialysis is incredibly uncommon with that condition. I think historically there had been concerns that people with that condition may be more prone to it, but this was in the days where we didn't have good imaging to detect problems such as ultrasound and good treatments, honestly, to deal with kidney stones should they form. So that is a very, very uncommon event nowadays, thank goodness.
And another question related to this. Do you have any specific advice for someone who has this kidney condition and has had significant issues with kidney stones over the past 4 years, and specifically 5 removal procedures?
Right. Well, in people with medullary sponge kidney disease, the underlying problem is they have a congenital anatomical condition. So what that means is the way the kidney developed, it predisposes to kidney stone formation. And sometimes there's not a whole lot we can do about that. That anatomy is sort of fixed, if you will. It's kind of a pre-existing condition that is really hard to deal with. However, having said that, about 50% of people who have medullary sponge kidney have other predisposing risk factors which cause them to form kidney stones. And for those people, absolutely, there's things that can be done, and sometimes some dietary changes or even medication can be used. About 50% of people with medullary sponge kidney have very high urine calcium levels, and that's something that's actually fairly easy to treat medically. So absolutely, depending on the scenario, there are things that can be done to reduce a patient's risk of stones who have that condition.
Okay, thank you. So 2 more questions here, Dr. Razvi. So what is the best way to seek medical help when a kidney stone persists?
Right. Well, I mean, if a person has that acute colic episode that I described, that excruciating pain that makes it hard really to function, to sleep, well, really the first order of business is to come to the nearest emergency department if the pain is that excruciating. I mean, if it's something that they can manage without strong pain medication, then they might want to contact their family physician first and get some guidance. But really, the problem with that acute colic is usually it is so intense that really in those situations it's kind of hard to tough that out. And really what you need to do is seek medical attention where you can get immediate evaluation, the proper pain medication to settle the pain, and if need be, access to urological care so that if the stone needs to be dealt with expeditiously, it can be done so. And really our current entry point is the emergency department for that.
Great. Okay. And we've actually got another one that just came in here. So is it possible to have a stone that moves around within the kidney, causing symptoms to come and go without ever passing the stone?
Yeah, that's an excellent question. I think that does happen. Yeah, it kind of depends on where in the kidney the stone is situated, but yeah, I think we do see that, and patients often do relate that, yeah, pain comes and goes, or even on our imaging test, sometimes we'll see that it looks like the stone location has moved. So yes, I do believe that happens.
Right. And the last question for the night, this is one about the future here. So do you have any advice for young people who may want to enter this profession and help tackle this issue?
Wow, what a great question. Yeah, we're always looking for interested people in this profession of urology, and certainly in kidney stones. I mean, there's lots of work to be done. If someone's interested in research, there's obviously ways through the universities, through our research institutes to get involved. Volunteering in labs as a starting point is often something that our students do, and they really find the work interesting, and that might then propel them to want to do further education, maybe a master's degree or a PhD in this area. And so that's often an entry point for them to learn more about a certain condition. For those that are interested in the clinical side, looking after patients with urologic conditions or for kidney stones specifically, we're always happy to have students come and see what we do, to shadow us, to see some of the technology we utilize. I think sometimes that's very helpful in terms of when they're planning their careers. So yes, we're always keen and very willing to hear from anyone interested in learning more.
Thank you, Dr. Razvi. That wraps up our presentation this evening, folks. Thank you so much for tuning in. Dr. Razvi, thanks so much for spending time addressing our audience questions and for the helpful advice. It's a great reminder to drink recommended amounts of water and consider vitamin D supplements, especially over the winter months. That was a great takeaway for me. So before we conclude tonight's presentation, I want to remind everybody about the DocTalks podcast. Tune in as award-winning journalist and longtime columnist for the London Free Press, Ian Gillespie interviews physicians and researchers from across St. Joseph's. You can put your headphones on and sit back, relax, and enjoy listening to Ian's common sense interview approach with some of the greatest minds tackling the biggest healthcare challenges of our time. Finally, a big St. Joe's thanks to our corporate sponsors, CIBC and the Seabrook Financial Group at CIBC Wood Gundy for making tonight's presentation possible. And on the topic of generosity, I want to personally thank our donors who allow St. Joseph's to stay at the forefront of medical innovation for the patients and residents we serve. And like Dr. Razvi mentioned, donors play a key role in helping keep great healthcare close to home. Thanks for tuning in and have a wonderful night. Thank you.